What's up, Ninja Nerds? In this video today, we're going to be talking about lipid-lowering medications. Lots of cool meds to talk about. If you guys do like this video, if it makes sense, you actually do enjoy it, you learn a lot, please support us by hitting that like button, commenting down in the comment section, and please subscribe. Also, you guys want some amazing notes, some illustrations that our Ninja Nerd team have put together, go down the description box below. We have a link to our website. You guys can check that out. All right, so please do that. All right, let's get into talking about this. So with lipid-lowering medications, we're treating hyperlipidemia as the whole process here, right? And patients who have hyperlipidemia, the basic problem with this disease is that they have very high LDL levels. Okay, and we'll talk about all these molecules. They also will have high triglyceride levels, or they may have low HDL levels. That's the basic concept of a patient who has hyperlipidemia. If you guys want to know a little bit about these more in detail, lipoprotein metabolism, go check out that video in our biochemistry playlist. It's lipoprotein metabolism. We go in way more detail. We're going to kind of simplify it here. So the basic concept of hyperlipidemia, we have to understand the physiology first of lipoprotein metabolism. So here's going to be the intestines, right? So this is going to be a part of your intestines, like a part of your small intestines, really. This is where we have absorption of a lot of different things. So when we talk about this, we have a lot of different molecules. So one of the molecules that we actually absorb across the GI tract that are important in lipid physiology is cholesterol. The other one is going to be free fatty acids. This is how we really get triglycerides across. And then we need something in order to be able to get the cholesterol, the free fatty acids, across the actual gastrointestinal tract. We need a very special molecule, and that molecule is going to be called bile acids or bile salts. So bile acids. These are really essential because what they do is the bile acids actually bind onto the cholesterol, they bind onto phospholipids and free fatty acids. They form kind of like this coating that enables it to be absorbed across the GI wall and into the lymphatic system. Right? And so whenever these actually go across, they go in the form of these things called micelles, and the micelles would get taken up into the enterocyte, they'll be metabolized and put into the lymphatic system. So here's going to be our lymphatic system. Now, once we actually put this molecule containing, so we're going to draw like a little vesicle or a little like structure here. This molecule right here is going to contain a lot of different like lipoproteins on its surface, but it's carrying lots and lots of cholesterol, lots and lots of triglycerides. This molecule that's carrying lots of triglycerides and cholesterol via the lymphatic system that'll get pushed off into your circulatory system, this molecule here is called a chylomicron. And chylomicrons have high amounts of triglycerides, and they also have high amounts of cholesterol, but tons and tons of triglycerides they carry. Whenever these molecules, cholesterol, free fatty acids, bile acids, the bile acids are really helping to absorb the cholesterol and the triglycerides into the lymphatic system. They get into the lymphatic system, and then they move into the actual circulation, all right, via the thoracic duct. Once the chylomicrons are here inside of our actual circulatory system, it'll move via the circulatory system, and then it'll actually come into areas of extrahepatic tissue. So this is going to be extrahepatic tissue, so tissue that is not the liver. And what's going to happen here at this extrahepatic tissue, we're going to have adipose tissue and skeletal muscle tissue. There's these special enzymes that are present on the endothelial surface. And this enzyme here is called lipoprotein lipase. And what lipoprotein lipase will do is, here's our chylomicron. Here's our chylomicron moving through the circulatory system. What the lipoprotein lipase will do is it'll actually take and break down the triglycerides that are present in this chylomicron and release them. So it'll take a lot of the triglycerides here, right, out, and it'll break them down into what's called free fatty acids. It'll break them down into free fatty acids. And that can be taken up into the skeletal muscle cells, be utilized for ATP, or it can be taken up into the adipose tissue and be converted back into triglycerides. But either way, that's how we help to remove triglycerides from the chylomicrons, is via this enzyme lipoprotein lipase. Remember that. Now, once that happens, this molecule, this chylomicron that actually relieved tons of triglycerides to get taken up into the extrahepatic tissue, is now called something else. So it's got less of the triglycerides. This is called a chylomicron remnant. This is called a chylomicron remnant. And again, it doesn't have as much triglycerides, but it does have a lot of cholesterol. What it'll do is it'll bind onto these receptors that are present on the liver. and it'll take this actual cholesterol and triglycerides and put this into the liver. Okay, it'll take up the actual triglycerides and cholesterol from this chylomicron and put it into the liver. Now, something really interesting in the liver can happen. The liver actually takes lots of different molecules. We'll go into this pathway a lot more later, but it uses things like acetyl-CoA, and from the acetyl-CoA, it'll actually be utilized to make something called cholesterol. We'll go into this pathway more a little bit later, but it's utilized to make cholesterol. Now we know that cholesterol can be utilized in many different things, to make steroid hormones, to make bile acids, and it can also be utilized to be able to make lipoproteins. One of the interesting things here is that triglycerides can actually be combined with the cholesterol. And when they're combined with the actual cholesterol, these two molecules here combine together just like a chylomicron, and the liver actually excretes this molecule out into the actual bloodstream. And this molecule here is called a VLDL. It's got lots and lots of triglycerides, and it's got a lot of cholesterol, but a lot of triglycerides, just like a chylomicron. It's just this is made by the liver. Now the VLDL will actually move via your circulation, your systemic circulation. When it moves via the systemic circulation, it encounters another enzyme in your capillary system near the what? Near the extra hepatic tissues, such as the adipose tissue and the skeletal muscle tissue. And what happens is at these tissues there is that special enzyme, the lipoprotein lipase. When this enzyme is activated, what it'll do is it'll take the VLDL molecules and it'll rip out what? It'll rip out tons of triglycerides and take and convert those triglycerides into free fatty acids that'll get taken up to the adipose tissue and stored as what? It'll be stored as triglycerides, or it can be taken up into the skeletal muscles and utilized to generate ATP. But the whole concept is that we're taking the VLDL up and removing lots of triglycerides. Once that happens, it then gets converted into another molecule. And this molecule is called a IDL. Then an IDL will then eventually, it'll actually relieve a couple more structures and actually become something called a LDL. So eventually it'll become a LDL. Now, LDL is really interesting. It's a lipoprotein that has lots and lots of cholesterol, but not as much triglycerides. So far you've noticed a trend that VLDLs and chylomicrons, those carry lots and lots of triglycerides, not as much cholesterol. So in patients who are going to have lots of these chylomicrons or lots of these VLDLs circulating around, they're probably going to have lots of triglycerides within their bloodstream. Patients who have lots of LDL carry a lot of cholesterol within their bloodstream as a particular problem. Now, this LDL is really interesting, and one of the problems with this LDL is that LDL loves to bind onto a lot of receptors that are present in extrahepatic tissues. One is the gonads, the adrenal cortex. Why? Why would LDL be important here? It carries a lot of cholesterol. Guess what this cholesterol can be used for? To make things like steroids, steroid hormones. So the gonads can use this to make things like estrogen, progesterone, testosterone. The adrenal cortex can use this to make things like aldosterone, things like cortisol, things like gonatocorticoids. You get the point. The LDL will actually take and give some of that cholesterol within its structure to these extrahepatic tissue to make steroid hormones. That's the benefit. But what's the bad side? The bad side of LDL is that it also can go to other extrahepatic tissues. You know, in our blood vessels, in the intimal lining, okay, in the subintimal lining, there's lots and lots and lots of these things called macrophages. And macrophages love to bind to LDL molecules. So they have on their surface, they have lots of these things called LDL receptors. They have like these different types of receptors. And what happens is when the LDL will bind with these receptors on the macrophages, so here's all the LDL molecules, it'll get taken up. And when it gets taken up into these macrophages, which happen to kind of situate themselves in the actual blood vessel wall, when it gets taken up, it takes up all this LDL and becomes filled and filled and filled with the actual fat globules. And then this macrophage gets converted into something called a foam cell. And then what happens is this really starts to accumulate a lot within the blood vessel walls. And so this can lead to a lot of fatty plaques that develop within the vessel walls. a lot of fatty plaques that actually start to develop within the vessel walls. And a problem with this is that it can really increase the risk of what's called atherosclerotic cardiovascular disease. That's one of the most dangerous components of this. But you get the point. So LDL, whenever there's lots and lots of LDL, there can be lots of cholesterol to go to these extrahepatic organs and be utilized to make steroid hormones, but it also can be utilized by foam cells and make these fatty plaques within the vessel walls. Now, once the LDL has been done with its job, what happens is the LDL will not only do this, but it'll take some of its LDL particles and go back to the liver. And on the liver, you have these things called LDL receptors, which will take the LDL up and really utilize and reutilize that cholesterol to make more VLDLs, to make more other molecules like cell membrane components, bile acids, all of those things. We're recycling the cholesterol. So that's one way that we can remove the LDL. Now there's one more protein here. We've talked about triglycerides really with the VLDLs and the chylomicrons. We talked about the LDLs. What about the HDL? Where the heck is that one? HDLs are also really cool. They're made by the liver. And so they not only are they made by the liver, but they actually are made by, there's something called an HDL pool. So some other molecules like chylomicrons and VLDLs and IDLs, they give a lot of proteins that help to make something called this HDL structure. But the liver definitely plays a big role in this. And so the liver will actually make something called an HDL molecule. So it'll make this HDL molecule. And HDLs are interesting. They don't really carry any cholesterol when they're first synthesized. So let's actually draw that there's really nothing in this. It's really just a protein. So this is a protein structure. What happens with the HDL is that it'll actually go to the blood vessel wall. So let's say here's a blood vessel wall. I'm gonna draw another blood vessel. It'll go to this blood vessel that has lots of fatty plaques within it. And it'll go near those foam cells that are in this fatty plaque wall and yank and rip some of the cholesterol and the fat out of the blood vessel wall. So this HDL, which is empty, will move through this circulatory area, pull some of the actual fat and cholesterol out of this, and now this HDL molecule helped to remove some of the plaques. So now what did it carry within it? Now it's carrying with it some of the cholesterol and the fats. Isn't that a cool concept? So HDL is really good at being able to do what in this situation? Pull some of the plaques from the actual blood vessel walls. So that's the HDL. So it's going to be carrying with it cholesterol and fat molecules. And then what it's going to do is it's going to take this to the liver. And on the liver, there's also going to be these different receptors that bind to the HDL and take the HDL back up and utilize some of that cholesterol that it pulled away from the vessel wall to make more lipoprotein molecules, to make more types of cell membrane components, make bile acids, etc. So if you kind of think about this, when a patient has hyperlipidemia, the disease process that really comes out of this is that if you have low HDL, you have an increased risk of not being able to remove as many of these plaques from the vessel wall. If a patient has high amounts of LDL, you have lots of fatty plaques that could be potentially formed. And in patients who have high triglycerides, again, triglycerides are also deposited into the fat walls. If patients have lots and lots of VLDLs, lots and lots of chylomicrons, again, that also can play a role into these fatty plaque formations as well as other organ dysfunction that we'll talk about. So in this concept here, this is really where we have hyperlipidemia. Now the question that you probably have is, what is the actual downside? What's the negativity? What's the problematic issue with having high LDL, high triglycerides, low HDL? Well, we know one of them is the fatty plaque development within the vessel walls. But you know, you can also have deposition into solid organs. What would that look like? Let's talk about that now. All right, so if a patient has lots of LDL, so lots of cholesterol, triglyceride deposition into the vessel wall, again, they have lots of triglycerides, lots of that can get deposited into the vessel wall or into solid organs. Less HDL to pull some of the triglycerides and cholesterol from the vessel walls, some of these, as well as some of these solid organs. What's the downside of that? Well, if we start depositing this into some of the actual tissue in the actual skin, this can lead to these things called xanthomas. So you can see these things called xanthomas. You can see other things, particularly, sometimes you can actually see a lot of these skin findings sometimes around, depending upon particular areas, around like tendinous areas. So you're going to see a lot of xanthomas. Another thing that you could see is you could see a lot of plaque deposits around the medial portion of the eye, lots of fat deposit around there, and that's called xanthelasma. So you can see something called xanthelasma, a lot of fat deposits really that you can see, not just here in the actual skin and around joints, but you can see this around the medial portion of the eye. You can also see a lot of fat deposition around the cornea, and they call this a corneal arcus. This is a corneal arcus. Corneal arcus. The other thing is you can see lots and lots of fat deposition into the liver, and then this can actually lead to like non-alcoholic fatty liver disease or hepatic steatosis, and this can actually be a pretty nasty disease as well if you have lots and lots of this fat deposition. So watch out for other things called hepatic steatosis. And then the last thing is whenever patients have extremely high triglycerides, this can really wreak a lot of havoc on the actual pancreas, and it can lead to something called pancreatitis. So watch out for pancreatitis seen with extremely high triglyceride levels. Usually as we're starting to see like greater than 500 or 1,000 milligrams per DL, we start seeing a higher risk of hyperlipidemia-induced pancreatitis. But that's the concept here. So if a patient has high LDL, high triglycerides, and low HDL, this could be some of the actual clinical features that we could see. The other one, which I think is the actual more fearful one and the actual dangerous, life-threatening types, is that if we get a lot of these plaques within the vessel wall. So if you have lots of triglycerides that are getting deposited here, if you have high amounts of LDL, you're depositing lots of cholesterol and triglycerides into here. And if you have low HDL, you're not pulling as much of the plaque and fat and some of the cholesterol and triglycerides away from the actual vessel wall. So you increase the risk of these fatty plaques. And again, this can lead to something called atherosclerotic cardiovascular disease. So if I start plaquing up these vessel walls, that can really lead to a lot of problems, especially perfusion past that kind of plaquey area. So generally this is going to reduce the blood flow around this area. So imagine if this blood vessel is actually supposed to be delivering oxygen to parts of the brain. What's going to happen? Now you're not going to be delivering oxygen to what? To the tissues of the brain. And so you can start seeing things like strokes. So watch out now, because now the patient has an increased risk of something called a TIA. They have an increased risk of a CVA. So these are some nasty things that you could potentially see. The other thing is if it's not perfusing the myocardium of the heart. So now I'm not getting enough oxygen supply to the myocardium of the heart. This can start to die. What is this called? This can lead to things like an NSTEMI. This can lead to things like a STEMI. Or this can lead to just your basic kind of coronary artery disease. So your angina, whether it be a stable angina, unstable angina, etc. But you'll see a form of coronary artery disease as another complication. The other thing is if I form plaques and I don't supply blood to the actual tissues of the lower extremities, because I have plaques within these vessel walls, then I can start having like these cold, non-well perfused extremities with lots of claudication during exertional exercises. And this could be something called peripheral artery disease with a very high risk of an acute limb ischemia. So these are some really big things that you need to be able to recognize and realize is a very potential complication from this disease. Now, the last thing that you really want to be asking is, what in the world increases LDL? What's the thing that increases triglyceride? What causes a decrease in HDL? The basic reason of why this stuff happens is really beyond the scope of this lecture. That's more of the pathophysiology. But this could be genetic. So this could be due to some type of familial type of process here, or it could be acquired. It could be due to certain disease processes like diabetes, like hypothyroidism, like nephrotic syndrome, medications, weight, increasing in weight, obesity, all of these things, dietary changes. So it's important to realize that there's a lot of things that can do this. But what we need to figure out is, how do I change this? So my goal is to figure out a lipid-lowering medication strategy that can work to either decrease my LDL, decrease my triglycerides, and increase my HDL. So I have a lot of different lipid-lowering medications that are going to work in this process to help me with that. And the ones that we're going to go through step by step here are going to be the HMG-CoA reductase inhibitors. This is the primary one, and they're really good at dropping your LDL. Niacin, really good at dropping the LDL, but really good at increasing your HDL, and a little bit of the triglycerides that can decrease them. Fibrates, they drop your trigs really well, and they have a little bit of an effect on, again, increasing your HDL. Bile acid sequestrants and cholesterol absorption inhibitors, they're really good at dropping your LDL. And then PCSK-9 inhibitors, super expensive, but they're really good at dropping LDL. So we'll talk about a lot of these drugs in detail, some of their adverse effects, and then we'll go through how do we have a very straightforward guideline approach by the ACC-AHA guidelines of how we should treat a patient who has hyperlipidemia. They have high LDL, they have high triglycerides and low HDL. And my goal is to do this. How do I do that? What's the therapy? What's the particular patient population that I need to be aware of? And go through that in a lot of detail. So let's get to it. All right, my friends, so we're gonna go through each particular drug. We've built a foundation now. We know how the lipoprotein metabolism works. We're gonna kind of take parts of that diagram and focus on how some of these drugs work in particular areas, right? So we'll kind of keep going back to it, talking about mechanism of action, tying it to the pathophysiology. What I really want you to understand, all of these drugs will have an effect on at some point any of those three parameters, the triglycerides, the HDL, the LDL. That is the case, yes. What I really want us to focus on primarily with each one of these drugs is what is the primary one or two of them that it really, really focuses and fixes in patients who have hyperlipidemia, okay? So we're gonna go over the mechanism of action and then which one of those three, triglycerides, HDL, LDL, does it primarily affect? Is there something else we should know? Okay, statins is the HMG-CoA reductase inhibitor category. So this is going to be, my friends, this is that terminology that you probably heard, the statins. And there is a lot of drugs in this category. What I want to do is I want to actually break it into two parts. One is called high intensity statins, and the other one is called your moderate intensity statins. I'm not going to go over all the dosages. I don't think it's really necessary. I'm going to go over two drugs and that's the only ones that I'll really talk about dosages for. So within this drug category, the first one that I'm going to talk about, I'm going to use this up arrow. Or let's put high intensity statins. And there's really only two drugs that I want you to know here. Okay? One is called rosuvastatin. Okay, rosuvastatin. And this drug, if the patient is taking 20 plus milligrams of rosuvastatin a day, so I'm going to put 20 plus milligrams, that is a high intensity statin. If they are taking atorvastatin, and they are taking 40 plus milligrams per day of atorvastatin, that is a high intensity statin. You'll see later why I'm differentiating these concepts. The next one is going to be your moderate intensity statins. Now, rosuvastatin and atorvastatin are in part of that category, but it's lower dosages, okay? So this would be rosuvastatin, and guess what? It just has to be less than 20 milligrams, just less than 20 milligrams. If it's going to be atorvastatin, it's going to be less than 40 milligrams. Not hard, right? Not hard to imagine. Now, the other drugs that I want you guys to think about that are a part of this category, one is called lovastatin. So one is called lovastatin. The other one is called fluvastatin. Another one is called simvastatin. And then the last one that I want you guys to think about is called pravastatin. Okay, but you get the point. I really think the easiest thing to think about here is that these are the statins. You see that name, you know that it's one of these drug categories, okay? And then you'll know their mechanism of action in a second. But the big thing is really understanding, because we'll talk about this when we get into the treatment guidelines, the differences between high intensity statins and moderate intensity statins, okay? So all of these are moderate intensity. Their dosages are different, okay? I'm not gonna go through all of that. I don't think it's that important. I really just want you to know that these are gonna be likely the most commonly utilized drugs. Rosuvastatin and atorvastatin, they're gonna be the most common. In this dosage range, they're high intensity. In this dosage range, they're moderate intensity. And then any of these drugs are considered a moderate intensity type of statin. Okay, that's enough of that. What we now need to talk about is how do these drugs work? What is their mechanism of action? It's actually really stinking cool. So here we have an hepatocyte. So I'm taking a liver cell and I'm zooming in on it, okay? So in this liver cell, remember I told you I used this like basic kind of concept that acetyl-CoA was utilized to make cholesterol. That is true. But the process of how it does that is actually a little bit more intense. So acetyl-CoA is actually going to be first worked and converted into something called mevalonate. So it's converted into something called, it's actually converted into what's called HMG-CoA first. Apologize. So first it's converted into what's called HMG-CoA. Then HMG-CoA is converted into mevalonate. And then mevalonate is converted into cholesterol. Now, We already know that cholesterol can be combined with something like triglycerides, right? So if we, for example, if I wanted to make this into something called a VLDL, what would I need to combine with the cholesterol to make this? I would have to add in some triglycerides, and I could make VLDL, right? That's one thing. Here's something else that's really interesting. Cholesterol acts as a modulator of LDL receptor synthesis. So here on the outside surface here is what's called an LDL receptor. Believe it or not, the number of LDL receptors is dependent upon the amount of cholesterol that is present inside of the cell. So generally here, for example, on our DNA, we maybe have a specific gene. Let's say here's the specific gene that makes the LDL receptor. Here, we'll actually do this. Let's take this, and just in this blue, I'm gonna put, there's the LDL receptor gene. Cholesterol will modulate this activity. And if we take this gene that makes LDL receptors and just go ahead and transcribe it and make mRNA. And then on this mRNA transcript, there's going to be a particular coding there. There's going to be a particular coding there that is going to be used to make the LDL receptor. Then what I'll do is I'll take that mRNA and I'll take it to the ribosomes and I'll translate it. And then I'm going to translate from this a particular protein structure. So here I'm going to translate from these ribosomes a particular protein. And this particular protein that I'm going to synthesize is going to get taken up by the Golgi, and it's going to get packaged and put into a very specific component here of a vesicle. So here I'm going to have this vesicle here, and this vesicle is going to go and fuse with the actual cell membrane and pump up the LDL receptor. Pretty cool, right? All right, cool. Here's where the actual statins come into play. There's a special enzyme that works right here that converts HMG-CoA into mevalonate. This enzyme is called HMG-CoA reductase. Not too hard to think about there, right? What I'm going to do when I give a statin is going to inhibit this enzyme. I will no longer be able to take HMG-CoA and convert it into mevalonate. What happens to the level of mevalonate now? It goes down. If I don't make as much mevalonate, I don't make as much cholesterol. If I don't make as much cholesterol and complex it with triglycerides, I don't make as much VLDL. And so therefore, VLDLs carry what type of molecule again? Triglycerides. And so what would I effectively maybe do to my triglyceride level? I may drop my triglyceride level because I'm not going to be carrying as many VLDLs in the blood. But here's where it's really cool, okay? Less cholesterol says to this LDL receptor, says, hey, I'm hurting. I need to bring in as many LDL molecules because they have lots of cholesterol. I need to bring as many of those LDL molecules inside because I need more cholesterol. I don't have enough of it right now. That's what the actual cell thinks. So here you have an LDL molecule out here. And let's say that you have a lot of them. Here's a lot of these LDL molecules sitting out here. And you want to bring these in, but I don't have enough receptors. Well, guess what? This low cholesterol stimulates the stink out of the transcription of this particular gene that is actually containing the LDL receptor. So that I enhance and I make more mRNA. I make more of the LDL receptors. I transport more of the LDL receptors onto the cell membrane. Now look at this. Look at this. I'm going to pump out tons and tons of LDL receptors all over this dang cell membrane. If I increase the expression of LDL receptors, what am I going to take out of the bloodstream? LDL. I'm going to rip LDL out of the bloodstream. And so the LDL levels are going to do what? They're going to fall. And so I'm going to significantly drop my LDL levels. So you see how statins, one of the best things for them is that they drop your LDL levels. They have a minor ability to drop your triglycerides. There's one more thing. How this mechanism actually works, I don't know. There's no potential literature on this. But there is some thought here that cholesterol may also, whenever there's decreased amounts, may somehow increase the synthesis of HDL. That whenever there's less cholesterol, it may increase the synthesis of HDL so that the HDL can go out, pick up more cholesterol from the peripheral plaques and the vessel walls and other organs and bring it back to him. Bring it back to the liver so it can make more, so it has more cholesterol there. And so theoretically, you may increase your HDL levels, but again, the mechanism of how it does this, there's no potential answer to that. But it may increase your HDL. But here's what I really want you to think about. With statins, the big thing that I really want you to remember is that these are going to be your first line, hyperlipidemia medication. And the primary thing that they will be good at reducing is LDL. So their main thing that they will reduce is LDL. They will have a minor benefit at reducing things like triglycerides and a minor increase in HDL. But this is the big thing that I really want us to focus on, okay? That's why I want us to focus on what's the primary thing that it can affect. But that's statins, and these are gonna be your first-line medications. Now, what's some of the adverse effects that you want to be careful of? Because a lot of drugs are metabolized, and actually specifically since statins actually go through the liver, so statins are really metabolized pretty decently through the actual liver, there can be some degree of metabolism that's occurring here that can actually cause some degree of increased cellular usage that can increase the patient's LFT. So it may cause a minor little hepatotoxicity that you want to be careful of. So watch for any increase in LFTs. There's one more thing. Statins have also been shown that what they do is they deplete a very specific molecule present in the skeletal muscles. And we see this in a lot of different statins, especially simvastatin. You may even see this with atorvastatin. You don't see it as much with fluvastatin and pravastatin, and we'll talk about this. But what we see with some of the statins is that they really deplete this molecule called coenzyme Q. Now you probably will know that coenzyme Q is actually important within the electron transport chain. It's an important component of the electron transport chain. So whenever a patient who has, the skeletal muscle, you're supposed to take and utilize oxygen, right? And that oxygen will get taken up, utilized by the skeletal muscles, and then pump out ATP to allow for muscle contraction. We know these things. But if you have less coenzyme Q, you're not going to have as much activity by the electron transport chain. And so this will end up inhibiting this process. And so you'll have less ATP to be able to allow for the muscles to contract and to perform regular functions. And this can lead to myopathy. So one of the things that you want to watch out for in this particular disease is that this can really cause an intense myopathy, which can maybe present in a couple different ways. One is it may just be pain. It may be weakness. What's worst case scenario is that you actually get what's called rhabdomyolysis. This is the worst case scenario, where sometimes this can actually be so bad that you want to watch out that the patient doesn't have elevated levels of creatinine kinase. Because the creatinine kinase can actually be one of the enzymes that actually leaks out of these muscles when it's super injured. So watch out for that. Another thing is that if the muscle gets injured enough, it can actually leak out something called myoglobin. And myoglobin is really hurtful to the kidneys. And if it gets stuck in the kidneys actually can really develop a pretty nasty injury to this from myoglobin. So another thing is watch out, because whenever a patient starts hurting their muscles, they can leak CK out, but they can also leak out myoglobin, and that can lead to an acute kidney injury. So the things that you really want to be thoughtful of with utilizing statins is monitor the patient's LFTs. It can cause a little bit of a hepatitis, not too bad though, but the main thing is that it can actually cause myopathy by depleting coenzyme Q10. And this can lead to less energy utilization within the skeletal muscles, which can lead to myopathy, which can present maybe only as pain, weakness, tenderness of the muscles. But if it gets really, really bad, it can lead to full-on rhabdomyolysis of the muscles, where they pop open, release things like CK myoglobin. That can be somewhat painful and actually at high risk of an acute kidney injury. So be careful. The ones that have less risk of rhabdomyolysis or myopathy is going to be pravastatin and fluvastatin. So these ones have less of the myopathy risk. So if a patient starts developing problems, consider switching them over to one of the fluvastatin or pravastatin, because those have less of a myopathy risk. All right, that covers this drug category, the HMG-CoA reductase inhibitors, or the statins. We know their mechanism of action, we know the different categories, we know the names, we know some of the adverse drug reactions, and we know the profound effect that they'll have on the hyperlipidemia profile. Now, let's go to the next category, and that's going to be niacin, or nicotinic acid. All right, so the next one is niacin. This one's actually an interesting drug. Now, one of the things I think is important to remember, we didn't actually go through this diagram a ton, but within adipose tissue, it obviously holds tons and tons of something called triglycerides. Okay, it holds tons and tons of triglycerides. Now, triglycerides, or we've kind of abbreviated them TG, can be broken down into something called free fatty acids. And there's a special enzyme that does do that, and that enzyme we're going to put here in red is called hormone sensitive lipase. And naturally what it does is it stimulates this pathway, okay? So it'll stimulate the actual conversion of triglycerides into free fatty acids by the adipose tissue. Now what happens is this free fatty acids can then be pushed out into the circulation. When they're pushed out into the circulation, they then can go to the liver. So this is going to be a liver cell. This is a hepatocyte. The free fatty acids are then taken up into the liver cell. Okay? Now, once it's taken up into the liver cell, your free fatty acids in the liver will then be converted back into triglycerides. Okay, they'll be converted back into triglycerides. Why is that important? Well, triglycerides, if combined with cholesterol, make what type of molecule? VLDL, right? So it's going to pump out a molecule called VLDL. So let's actually pump this one out here. So if it combines with what? If it combines with the cholesterol, the triglycerides and the cholesterol make a molecule called VLDL. And then what we know is that VLDL can eventually be converted into IDL and then eventually into LDL. Okay. That's the concept that we have here. We know this thing now. What also is really, really interesting now is that if I give the drug niacin, what niacin is going to do is niacin is going to work to inhibit hormone-sensitive lipase. If I inhibit hormone-sensitive lipase, I inhibit the conversion of triglycerides into free fatty acids. That means I make less free fatty acids. That means less free fatty acids get pushed out into the circulation. That means less of them get taken up into the liver, make less triglycerides. Less triglycerides combine with less cholesterol. And if I have less triglycerides and less cholesterol combined, I lead to less VLDLs. And if I have less VLDLs, remember, what do VLDLs give up? What do they release into the extrahepatic tissue? Triglycerides. And so what am I technically going to lower within the blood? I'm going to lower triglycerides. So I will lower triglycerides. The other thing is that if I have less VLDL, what else do I lower? I lower my LDL. So I can lower triglycerides, and if by virtue I have less VLDL that's being synthesized, I'll have less LDL that'll be synthesized. So I have less of the LDL to actually bind onto these different plaques within the actual vessel walls. So far what I'm noticing with niacin is it's able to drop the VLDLs, which can drop your triglycerides, and by virtue, if you have less VLDL, you have less LDLs that you're going to make. Okay, here's where it's really, really interesting and profound, really, when you think about it. We know that the liver makes that molecule called HDL, right? And what's really interesting about HDL is that HDL, it can take right here. So we took here this vessel. Here's this vessel. And here it has a plaque within the vessel wall, right? There's a plaque within this vessel wall. And what we know is that HDL will actually try to go to these plaque where these macrophages are, these foam cells, lots and lots of foam. Remember, lots and lots of cholesterol kind of held within these macrophages. And what it's going to try to do is it's going to try to pull and rip out some of the cholesterol out of these macrophages. It does it because it binds onto these things like scavenger receptors. I'm just going to put SR. So these are scavenger receptors. What happens is the HDL will bind with these scavenger receptors. And sometimes what can happen is the macrophage can do two things. One is it can actually lead to the catabolism of these HDL molecules. So generally HDL is going to want to try to suck some of the cholesterol out of the macrophages. But sometimes what can happen is we can actually catabolize these puppies. So we can sometimes catabolize the HDL. And what would that do to the effective amount of HDL within the bloodstream? That would lower the HDL within the bloodstream. That's one thing. The second thing is if the HDL is successful and it rips some of the plaque out of that vessel wall, so here's the HDL. The HDL, after it rips some of the plaque maybe from the vessel wall, then what it does is it's supposed to go to the liver. It's supposed to go to the liver and bind onto the liver. Here's the HDL molecules. And then be kind of reuptaked and then kind of sometimes recycled into the liver, right? So then from here, they'll get taken up into the liver. And what would that do to the amount of HDL within the bloodstream? That would effectively lower the HDL levels within the bloodstream. Here's what niacin decides to do. Niacin says, I'm going to go ahead and I'm going to inhibit the catabolism of HDL at the scavenger receptors. So I'm going to decrease the catabolism of HDL. If I decrease the catabolism of HDL, I'm going to allow for more of the HDL to be present within the bloodstream. Here's the other thing niacin does. Niacin also inhibits the reuptake, or the kind of like utilization of the liver from HDLs. And so then what do? I don't take up as much HDL, and I keep more of the HDL within the bloodstream. So I'm increasing my HDL molecules. So really, when you think about what niacin is actually doing here, what is niacin really doing? Niacin is pretty decent at being able to do what? It's not your first-line medication, it's more of an add-on therapy. And really the most profound effect that's really interesting here is that it can increase HDL by reducing its catabolism and by reducing its reuptake. So that's one of the most profound and interesting concepts here, is it can increase your HDL. It can increase your HDL molecules. Not many other drugs will be able to do that. So it increases your HDL. The other thing that it can do is it also has the ability to decrease your VLDL, which will decrease your triglycerides. So it'll also drop your triglycerides. And it also can drop your LDL. It can also drop your LDL. So there's three profound effects of this drug. One is it can increase HDL, the other one is it can drop your triglycerides, and it also can drop your LDL. It can drop your LDL. So that's how niacin will be utilized in this situation. And I want you to remember the primary one here, which is going to be, it can increase HDL, but it also can drop your triglycerides and drop your LDL. Now, with niacin, again, it's not a first line, it's usually an add-on. So if a patient has they're on a statin, right, and they're utilizing it to lower the LDL, and the LDL still isn't in goal, you can consider niacin, especially if you want to drop the triglycerides too and increase their HDL. That might be a beneficial situation. But what's the downside? What's the actual adverse effects, which is the problematic thing with niacin? One is that in the proximal convoluted tubule within your kidneys, there's a transporter called an organic acid anion transporter. And what it does is it takes a molecule called uric acid. I'm going to use a U here, uric acid, and it excretes uric acid so that uric acid can end up into the urine. So here would be uric acid. We would want to increase the uric acid in the urine. Okay? Now, with niacin, niacin has the ability to inhibit this process. It's a son of a gun, isn't it? Niacin can inhibit that transporter. Now you can't excrete uric acid. So uric acid doesn't end up in the urine, so there's less uric acid that ends up in the urine, and more of the uric acid actually stays in the bloodstream. If more of the uric acid is not actually being excreted and more of it stays into the bloodstream, now we have what's called high uric acid in the blood. And this is called hyperuricemia. What is a risk factor if you have high uric acid? What can that do? That can deposit into the big old toe and increase the risk of gout. So that is one potential problem out of this disease, is that it can cause hyperuricemia, which can increase the risk of gout. So I would not give that to a patient who already has gout, niacin, okay? Second thing with niacin is that niacin has also potentially been shown to inhibit the insulin release, or maybe even cause insulin resistance in some way, shape, or form. So now, if I am not making insulin, or if the insulin that's actually being released is not responding, your receptors aren't responding to the insulin, that's a problem. So let's say that there's less insulin, or there's less insulin response. Generally, what that's supposed to do is take glucose and bring glucose into the actual cells. But if I have less insulin, or I have less responsiveness of the insulin on the receptor, I don't bring as much glucose into the cell. And so what happens to the blood glucose levels? They increase. So another adverse effect with niacin is that it can actually cause hyperglycemia. Okay. One more, and happens to be the most interesting concept here. There's a pathway here where you take a molecule called arachidonic acid, and generally one pathway is you convert it into leukotrienes, the other one is you convert it into prostaglandins. Well, what niacin has been shown to do is niacin can actually stimulate the arachidonic acid pathway to form lots and lots of these prostaglandin molecules. And if you make lots and lots of these prostaglandin molecules, what this does is this acts on your blood vessels in the skin and causes them to vasodilate and increase capillary permeability. And what that can do is that can actually cause a lot of flushing of the skin. And so one of the things that you want to watch out for here is that it can lead to flushing. It also can activate some of the mast cells and lead to histamine release, which can lead to pruritus. So watch out for any kind of flushing, pruritus types of sensations as well that you can see potentially with niacin. So with niacin, the big things to think about is it inhibits hormone-sensitive lipase, which actually inhibits triglyceride to free fatty acid breakdown. Less free fatty acids taken up by the liver. Less of it can be utilized to make triglycerides in the liver. Less combines with cholesterol to drop the VLDL. If you have less VLDLs within the blood, you don't have as much triglycerides within the blood. So you drop your triglycerides. Also, if you have less VLDL, you'd make less LDL, so it drops your LDL within the blood. And it inhibits the actual the scavenger receptor, so it inhibits the catabolism of HDL, and it inhibits the reuptake of HDL, which increases HDL within the blood. All of these things will be somewhat beneficial in a patient with hyperlipidemia. Not first line though. Watch out for hyperuricemia, watch out for hyperglycemia, and watch out for a lot of this problem with vasodilatory effects such as flushing, pruritus, a lot of the itching that you can see with that. You can treat this with aspirin or ibuprofen. So aspirin and ibuprofen are basically a part of the COX enzyme process. So if I gave a patient such as something like aspirin, so I can actually prevent this, I can treat this with aspirin or ibuprofen because they're going to inhibit the arachidonic acid pathway by inhibiting the COX enzymes. Okay, keep your mind clear. All right, now that we've talked about niacin, let's move into the next drug category, which is gonna be our fibrates. All right, so now fibrates. Fibrates are actually gonna be two drug particular names that you wanna remember here. One of them is called fenofibrate. So one is called fenofibrate. It's actually not too bad, right? Because that's kind of within the name of the drug class. And the other one is called gemfibrozil. Gemfibrozil. Now, with these two drugs, okay, what is the basic kind of mechanism of action? How are they working? What are they doing? It's actually really stinking cool. So, you know your liver. We obviously know that it will take things like acetyl-CoA, utilize that to make cholesterol, and then if it takes the cholesterol, combines it with triglycerides, it makes something called VLDL. We know that that's the main lipoprotein that's made by the liver. Okay, now, once this VLDL, which is made by the liver, is going to be moving through the circulation. We know it encounters a very special enzyme in the extrahepatic tissues. So this could be in the skeletal muscle area, this could be in the adipose tissue. We're just happening to pick the adipose tissue in this particular example, but you could have some skeletal muscles here as well. We know there's a special enzyme here called lipoprotein lipase, and we know that what it does, it takes the triglycerides from the VLDL and from what other molecule? Good question. So from the intestines, you absorb a molecule here that carries a lot of triglycerides and a lot of cholesterol as well. And this molecule is called, that carries a lot of triglycerides and a lot of cholesterol is called chylomicrons. I'm going to put CHYL, okay? But this is going to be a chylomicron. This is coming from the GIT. So from the GIT, you're going to absorb this chylomicron. And again, these both, if you look at the VLDL and the chylo, we know that they carry tons and tons and tons of triglycerides. They carry cholesterol, but not as much as they do triglycerides. Now, this enzyme, when it's active, what it does, it takes from the VLDL. We know that the VLDLs will eventually get converted into IDL and then into LDL. And we know that chylomicrons will eventually get converted into something called chylomicron remnants, right? So we know these concepts. We already talked about in the phys. What we did say also is that from these molecules, what we would do is we would rip from them what? Triglycerides. Then the triglycerides, when acted on by the lipoprotein lipase, does what? Converts it into free fatty acids, which is taken up by the what? Adipose tissue. So it takes it up as free fatty acids, because the lipoprotein lipase is going to convert that into free fatty acids. So all of these free fatty acids will get taken up into the adipose tissue, the skeletal muscle tissue, utilized to make more triglycerides. So we know that within this adipose tissue, it'll take the free fatty acids and make triglycerides. If it was in the skeletal muscle, it would use it for energy, right? Concept there, done. LPL is utilized in this step here. So what LPL does is, we'll do it with this red arrow, or this red situation here. LPL works here to stimulate this particular pathway. That's what it does. What if I had a drug that could really enhance the activity of this lipoprotein lipase, and it just takes and sucks all the triglycerides away from the VLDL and the chylomicrons, puts it into adipose tissue or puts it into skeletal muscle to be utilized for energy? Because again, just for the sake of it, I want you to also understand that there is, again, some skeletal muscle out here that I can also utilize it. So here could be some triglycerides that'll be taken up into the, well, again, it'll be free fatty acids, taken up into the skeletal muscle and be burned to make ATP. So we could utilize it in those two ways. What if I had a drug that could enhance the activity of the lipoprotein lipase? Wouldn't that be cool? Guess what the fibrates do? That's what they do, my friends. So fibrates are pretty darn cool, that they basically work to enhance or stimulate the activity of the lipoprotein lipase. And so that stimulates the actually breaking down of triglycerides. So now we're taking a lot more of these triglycerides and breaking it down into free fatty acids to be taken up into the adipose tissue or into the skeletal muscles. So what happens to the total level of triglycerides within the bloodstream? That's what I want you guys to think about. What happens? This triglyceride level is going to plummet. So the triglyceride levels are going to plummet. So that's why this drug, fibrates, are the absolute best at dropping the patient's triglyceride levels. Now, by virtue, if you drop their amount, if you yank, as you actually convert a lot of their VLDLs and break them a lot down, you could also drop the patient's LDL, right? So you may also see that as well. There's one more mechanism that's really cool though with fibrates. They love to stimulate the liver, and they love to tell the liver, hey liver, I need you to make lots and lots of HDL. So one of the other cool concepts here is that this fibrates also will increase the production of HDL. So fibrates have the ability to also stimulate the liver to increase the synthesis of HDL. So what I really want you to understand with fibrates is, if I were to kind of highlight what they're really doing with their mechanism of action, because we already know that when we talked about the statins, they really drop the LDL. That was the primary mechanism. Niacin, it drops triglycerides, it drops LDL, but the biggest thing is that it really increases HDL. With the fibrates, what are the two things that it's really doing? It's increasing HDL and it's decreasing triglycerides. That's the big thing here. So it's increasing HDL and it's also decreasing triglycerides. So it's similar, if you think about it, to niacin. It's similar, if you think about it, to niacin. Because niacin also increased the patient's HDL and it also dropped the patient's triglycerides. Because what did it do? It decreased the amount of VLDL. Because then the liver didn't have as much triglycerides to bind with the cholesterol to make VLDL. So niacin and fibrates, if you think about it, act similarly, that they both increase HDL and drop triglycerides. But which one's better at dropping triglycerides? Fibrates are going to be better at dropping triglycerides than niacin. But both of these will help to decrease LDL, increase HDL, and increase triglycerides. But which one's better at dropping triglycerides again? The fibrates in comparison to niacin. All right, that's a pretty cool concept there of how these drugs actually work. What's the downside? Well, one of the downsides is if you have a patient who's on a statin. So if you have a patient who's on a statin and they're on a fibrate, the downside is that the muscles will not be a very big fan of you. The reason why is statins are basically going to be taken and metabolized by the cytochrome P450 system, right? That's how they work. They get metabolized via the cytochrome P450 system. If you give a fibrate, what a fibrate does is it works as a kind of a CYP450 inhibitor. And it's going to inhibit the actual cytochrome P450 system from breaking down statins into the inactive metabolite. And so what essentially happens is you increase the amount of statin now, okay? And if a patient is having myopathy as it is, now you're gonna have a higher statin level. And what that's gonna do is it's gonna deplete the amount of coenzyme Q. So the CoQ is going to ba-boop, ba-boop, ba-boop. And what's this gonna lead to? This is gonna lead to myopathy. worsening myopathy. So watch out for these patients to have worsening myopathy with a statin and a fibrate combo. So if a patient is on a statin and they're also taking a fibrate, watch out for myopathy, as well as watch out for maybe a slight bump in the LFTs. This may also increase the LFTs a little bit as well. Okay, so another potential adverse effect here is slight transaminitis, but primarily myopathy. There's one more, okay? So with HMG-CoA reductase, this was increased LFTs, myopathy. With niacin, it was the flushing pruritus due to the vasodilatory from increased prostaglandins, hyperuricemia, and hyperglycemia. With fibrates, it's concomitant use with statins increases myopathy, increases LFTs. So it's just basically statin ADRs. But one more, gallstones. You're like, what the gallstones? Fibrates are really interesting. So there's an enzyme that's involved in making something called bile acids. So we have this molecule called bile acids. And then another thing that's a part of bile. So bile is actually made up of two primary things. One is cholesterol. And the other one here is going to be bile acids. So you have things like cholesterol and bile acids and phospholipids. These are the big components, though, of bile. So this is really what kind of makes bile, okay? Now, when I give a fibrate, what a fibrate does is there's a special enzyme that's involved in the bile acid synthesis, okay? And this enzyme is going to be inhibited. So what fibrates do is they inhibit this particular enzyme. And what is this enzyme? Here's this enzyme that is important here. This is called 7-alpha hydroxylase. I'm going to kind of abbreviate it here. What fibrate does is it inhibits the 7-alpha hydroxylase. This is inhibited. So now the synthesis of bile acids is going to decrease. If I have less bile acids, now I'm going to have relative more cholesterol. This imbalance between less bile acids and high cholesterol leads to a supersaturation kind of event and precipitation of what? Gallstones. And this can increase the risk of cholelithiasis. So watch out that fibrates, be very careful and cautious that these patients may have an increasing risk of cholelithiasis because it inhibits the 7-alpha hydroxylase, which is an enzyme involved in bile acid synthesis. If you have less bile acids and a relative increase in cholesterol, the combination or the ratio here that's important in bile production will lead to an increased risk of gallstones, which can be sometimes problematic, and increase the risk of cholecystitis or choledocholithiasis, so watch out for that. All right, so that is our fibrates. We now know the drug, two drugs. We know the mechanism of action here. We know what's the primary effect that they're going to do on the lipid profile, and we know the adverse drug reactions. Let's move on to the next category, which is the bile acid sequestrants. All right, bile acid sequestrants. These are pretty interesting drugs. So there's a couple of them. One is going to be what's called cholestyramine. Another one is called colistipol. And then there's another one called colsevelem. Now, these drugs are relatively interesting. Now, one of the things about bile acid sequestrants is that, again, they're not first line. Obviously, statins are the first line, but what they do is really cool. So if we go back to the GIT, so here was where we're at the GIT within the intestines, right? I told you that there was three particular molecules that were involved here. One is we had something like cholesterol. So we had, well, the first one was bile acids. We actually did that one in green. So let's actually write that one down here. So we have, actually we'll put it here. So there's going to be bile acids, which were combined with what else? What else were they combined with? They were also combined with free fatty acids, and they were also combined with cholesterol. And the whole concept is that these would be absorbed. And when they were absorbed, again, bile acids would basically facilitate the absorption of cholesterol and free fatty acids, which would help to make a particular molecule called chylomicrons, and then chylomicrons would eventually get into the bloodstream, right? That's what we know. Bile acids they don't actually get absorbed with this process. They just are incorporated because, remember, cholesterol and free fatty acids, in order for them to be able to get to the actual enterocyte and to get absorbed, they need to be combined with bile acids to allow for them to be better absorbed into the intestinal fluid. So bile acids help to make those molecules called micelles, which helps aid in fat absorption. But What's really interesting in bile acids is that these are negatively charged molecules. So what I'm going to do is I'm going to give a drug, because naturally what happens is bile acids, after they're done helping with fat absorption to make chylomicrons and to get cholesterol and triglycerides into the bloodstream, what they're supposed to do is they naturally are absorbed, okay, into what's called the enterohepatic circulation. The enterohepatic circulation. This is basically a circulation where from the intestines, the bile acids are taken up and then brought to the liver. So this is going to be the liver. And then from the liver, what we know is that the liver is going to be taking molecules like cholesterol, right? It takes molecules like cholesterol and then synthesizes things like bile acids. We also know that it does a lot of other things with the cholesterol. Not only does it make bile acids, it makes things that are important in the cell membrane. It makes things like VLDL. We know that whole concept. But bile acids are generally really interesting in that there's one thing that we can do is that we can relatively recycle these. And then if we recycle these, what we'll do with these bile acids is that we'll put them back into the biliary circulation. So we'll put this into the bile. So here's the biliary circulation. So this is going to be a part of our bile. And then from here, we'll put them back into the intestine. So there's just this kind of continuous cycle with bile acids, that they're made by the liver, they're put into the GIT, they're helpful in absorbing fat molecules such as cholesterol and free fatty acids into the actual lymphatic system, and then eventually they get into the circulation. After bile acids are done helping with fat absorption, as they get to the distal part of the small intestine, they get reabsorbed. When they get reabsorbed, they go back via the blood to the liver via the enterohepatic circulation and get taken up by the liver. And then again, from there, they go back into the bile. So it's just a nice recycling of this molecule. What if I gave a drug that didn't allow for that process? So what I'm going to do is I'm going to give another drug. I'm going to give them a bile acid sequestrant. And this bile acid sequestrant is extremely positively charged. So it's a cationic molecule. And what it does is it binds onto the bile acids. And when it binds onto the bile acids, the bile is then going to be lost in the poo-poo. So then what I'm going to do is I'm going to excrete the bile acids into the feces. So now these bile acids are gone. So my bile acids are going to be bound to this bile acid sequestrant, and they're going to be lost into the poop. So now what that does is that leads to less bile acids that are actually going to be reabsorbed into the enterohepatic circulation. So that means that what I'm going to do is I'm going to bind these together, they're going to be fused together, and I'm going to poop it out. So they're going to go into the feces. Then I have less of the bile acids that are actually going to be brought and recycled via the enterohepatic circulation. So now what happens to the amount of bile acids that are present in the enterohepatic circulation? If I bind these up, it drops. So I have less bile acids in the blood. That means less bile acids are brought here to the liver to be incorporated into the bile and then be reutilized. So now I got a problem. I'm not going to be able to absorb cholesterol and fat as well. So the liver says, oh, dang it. Okay, well, I was diverting my cholesterol into utilizing this for other things such as VLDL and such as making cell membranes and other lipoproteins. Well, I guess I got to start taking this cholesterol and synthesizing more bile acids. So the cholesterol that we were utilizing to try to make more bile acids, guess what happens to it? It diverts it away from other pathways. We'll talk about what those pathways are in a second. But now cholesterol is going to have to go to make bile acids so that it can put more of that bile acids into the biliary circulation to absorb more fats. Because we're not recycling it right now, we're pooping it out. What happens to the level of the cholesterol now? It's going to plummet. I'm going to drop the level of cholesterol in the liver because I'm using it to make bile acids. Do you guys remember that process that I told you? That if we go back to the hepatocyte, if we were to go back to the hepatocyte here, in the hepatocyte, what we were noticing is that whenever a patient had lower levels of cholesterol, so they had low cholesterol, what that did is that stimulated DNA to RNA, RNA to proteins, and then what we did is we expressed a very specific type of protein on the cell membrane to make more of these proteins to pull more of the specific molecule back into this cell. So if there's less cholesterol because we're diverting it into making bile acids, that's going to stimulate the DNA, the genes that make LDL receptors. That'll increase the RNA, increase the proteins, and increase the number of LDL receptors. If I increase the number of LDL receptors, all of these LDL molecules will be taken up into the liver, and I'll effectively drop my LDL levels. I'll drop the LDL levels. So one of the concepts here is that low cholesterol that was supposed to be, it's all being shunted into making bile acids. What it's going to do is it's going to stimulate the formation of an increase in LDL receptors. And by making all of these LDL receptors, we're effectively going to lower the patient's LDL because we're going to pull more LDL into the actual hepatocytes, and so less of them are going to be within the circulation. Isn't that stinking cool? So one of the things that I really want you to remember about bile acid sequestrants is you bind onto them, you poop them out, you don't reabsorb them. Less of it is in the enterohepatic circulation, less of it's taken back up into the liver. That means that now you have less of it to add into the bile. That means that you won't absorb cholesterol and fat as well. Your liver says, okay, I'll divert my cholesterol away from something else into making more of you. When I make more of you though now I'm going to create that feedback loop that tries to increase LDL receptors. If you increase LDL receptors, you pour more LDL into the hepatocytes. Why? Because LDLs carry cholesterol. If I pour more LDL in, I'll have more cholesterol to use to make bile salts and other different things. So that's the cool concept behind this. The other unfortunate side effect out of this, and it's not well understood, but in this process of making bile acids, it may activate certain fatty acid enzymes that are important, or certain enzymes that are important in fatty acid synthesis. And so as a potential adverse effect here, something that we may see is an increase in triglycerides. There may be an increase in triglyceride synthesis slightly. And so one of the things that you also want to watch out for, this is actually a downside to this drug, is it may slightly increase triglycerides. So again, two potential concepts to understand here. One, bile acids, they're bound to bile acid sequestrants. They get pooped out. Less of it gets recycled. That means less of it can get put into the bile. It means you'll have less cholesterol and fat absorption. Cholesterol says, okay, I'll divert myself all into you, and so I'll make a lot of you. So as you start utilizing cholesterol to make more bile acids, you deplete the cholesterol within the hepatocytes. If there's less cholesterol, they stimulate the synthesis of LDL receptors. If I make more LDL receptors, I pull more LDL into the hepatocyte, lowering the LDL levels, because I want to take the cholesterol from LDL and make more cholesterol. As a downside to this, because a lot of the enzymes that are utilized to make bile acids, they're also utilized to make triglycerides. So triglycerides might also, unfortunately, bump as a result of this drug. So to take away from this, bile acid sequestrants, their basic effect on the lipid profile, bile acid sequestrants, their basic effect on the lipid profile is to do what? Two things. One is they will significantly drop the LDL and they will slightly increase the triglycerides, which is a down thing. That's a downside, right? So they'll drop the LDL and they'll increase the triglycerides. So one of the adverse effects of this drug is unfortunately hypertriglyceridemia. It may actually bump the triglycerides. So it might be something that you want to avoid in a patient who has hypertriglyceridemia. So that's one of the downsides. Okay, so we understand three of these drugs. We understand their mechanism of action, that they inhibit bile acid reabsorption, doesn't get recycled, cholesterol has to divert to making more bile acid, so it leads to an increase in LDL receptors, drops your LDL, but because some of the enzymes that are making bile acids are also involved in fatty acid synthesis, it can make more triglycerides. What's the other adverse effects besides hypertriglyceridemia? Well, not only is cholesterol and free fatty acids and being absorbed important with bile acids, but guess what else? Whenever you're absorbing any kind of fat, whether that be cholesterol, whether that be free fatty acids or anything like that, guess what else combines with that? Vitamins A, D, E, and K. And in order for this process to occur, for us to absorb fat and to absorb fat-soluble vitamins, what do I need to facilitate this process? I need bile acids. So bile acids are extremely important to facilitate this process. If I bind them up and poop them out, am I going to be able to absorb fat and fat-soluble vitamins? No. So when I give a bile acid sequestrant, so now I'm going to give a bile acid sequestrant, that is going to inhibit bile acids. The bile acids will no longer be able to enhance the absorption of fat and fat-soluble vitamins. So what happens to the absorption? You decrease the absorption of fat and you decrease the absorption of fat-soluble vitamins. There's one more downside. Another downside to this is that there's two drugs that are also really important and unfortunately can interact with bile acid sequestrants. They're unfortunately interacting with bile acid sequestrants. So here's going to be the GIT and here's going to be the circulation. There's two drugs. One is called digoxin, which is going to be a drug that we can utilize in heart failure as well as in AFib. And another one is called warfarin, which is basically an anticoagulant. When these drugs are absorbed, guess who interacts with them? Bile acid sequestrants. They can bind onto them. If bile acid sequestrants bind onto them, they will inhibit the absorption of digoxin, inhibit the absorption of warfarin. If you have less digoxin in the blood, that actually may lead to the patient not being as well rate controlled and not be able to treat their heart failure. If you have less warfarin within the blood, now the patient's at higher risk of clotting. So this is the downside to these drugs. You know what is actually kind of a positive? If patients decide to take too much digoxin, they try to overdose on it, or they take too much and they forgot, guess what they could take to potentially bind that up and actually act as kind of an antidote? You can give them cholestyramine, cholestyramine, colesevelam, because they'll bind onto the digoxin and help it to get pooped out. So we now know the names of the drugs, the mechanism of action, their effect on the lipid profile, and the adverse events, which is hypertriglyceridemia and decreased absorption of fat-soluble vitamins and decreasing drug concentrations of digoxin and warfarin within the bloodstream. Okay, my friends, let's now move on to the next one, which is your cholesterol absorption inhibitors. All right, my friends, cholesterol absorption inhibitors, these are pretty cool drugs as well. They're actually very commonly utilized. I'd actually say that this is one of those like second line medications that you can add on with a statin. It's pretty decent. And I actually, like, sometimes if a patient can't tolerate like a statin, this is actually would be the second line drug. So that's a really important thing to be able to remember. And there's two reasons for that. One is that they have very little adverse effects and they can profoundly drop your LDL. So for these drugs, there's really just one, and that is ezetimibe. And how do these drugs actually work? It's actually pretty cool. So from your GIT, so here's your GIT, right? So through your intestines, you're gonna have those different molecules. So we already talked about them. One is that you'll take cholesterol, and you'll also combine this with free fatty acids. If you wanted to, you can add in there the vitamins A, D, E, K, and then you can also add in the last molecule that's important in being able to help with the absorption of these molecules across the GIT, and this is your bile acids. We already talked about how the bile acid sequestrants will bind onto these, prevent their reabsorption, inhibiting the bile acid recirculation process, and then we talked about all that already. We don't need to go over that anymore. Now, here's where it's really cool. Now, cholesterol, free fatty acids, all of these things are basically absorbed across the GI tract. And eventually what happens is they actually technically have to go through, we know that they go via the chylomicrons. So they go via the chylomicrons. So here we'll put like your lymphatic system. They actually move into the lymphatic circulation first. So let's actually just follow cholesterol. We know that they go through the actual lymphatic circulation first, then they get into the actual blood, and eventually we know that they're going to go to the liver. So we know that the chylomicrons, especially the remnants, especially the remnant here, we'll put chylomicron remnants. We know that these are going to take and bring the remaining amount of cholesterol and a little bit of triglycerides, so chylo remnants, to the liver, okay? They bring it to the liver. And when they bring it into the liver, they push the cholesterol in here, okay? Now, what we know is that cholesterol is obviously very important to be able to make a lot of different things, okay? We obviously know that it can make bile acids. We obviously know that it can make VLDL. We obviously know that depending upon the amount of it, it also controls the expression of LDL receptors. So with this particular drug, here's what we're gonna see. When we give a cholesterol absorption inhibitor such as ezetimibe, it's going to inhibit the absorption of cholesterol. That means that the amount of cholesterol being carried by the chylomicrons is less. So there's going to be less cholesterol present within these chylomicrons. That means less cholesterol will be taken into the liver. Oh my gosh, do we already know this mechanism? If there's less cholesterol present within the liver, okay, what's the downside to that? Well, I guess actually it's a good thing. One is it's going to increase the expression of what kind of receptors? It's going to increase the expression of LDL receptors. And so if we increase the expression of LDL receptors, what are we going to do then? I'm going to increase my number of LDL receptors. Because again, we already talked about this before. The whole mechanism is that it actually does what? Low cholesterol stimulates the synthesis of DNA to RNA, RNA to proteins. Proteins such as LDL receptors are then packaged, sent up to the cell membrane so they can bind LDLs, bring more LDLs in, so that LDLs that have lots of cholesterol can try to increase the cholesterol in the liver. That's the whole concept. So if I increase the number of LDL receptors, what I'm going to do is I'm going to bind way more LDL molecules. And I'm going to bring them into the liver and remove them from the blood. So I'm going to drop the LDL molecules. Ooh, that's pretty cool. So that's one concept. The other thing is that if I have less cholesterol, less of this cholesterol combined with triglycerides. So if I have triglycerides that are actually available here, there's going to be less cholesterol to bind with the triglycerides. So this will effectively drop the number of VLDL molecules. So this may drop the VLDL as well. And if you drop the VLDL, you may slightly drop the triglycerides in this patient population, but it's not going to be profound. So this may drop the triglycerides. But I think one of the biggest things to think about here is the profound effect that it's going to have on the LDL. So when we talk about this, again, how do these drugs really work? Ezetimibe, it works to inhibit the absorption of cholesterol across the GIT into the lymphatic circulation, meaning you're going to have less chylomicrons that get absorbed. If I have less chylomicrons, so these are chylomicrons, I'm going to have less chylomicrons. Then after they go through the circulation and then they interact with the, again, we know that it interacts with what type of protein in the circulation. Here, we'll just draw for completeness sake. There's an enzyme here, which is around the extrahepatic tissues, the lipoprotein, lipase. After it then gets metabolized, it's then going to contain less triglycerides and mainly just cholesterol. This is a chylomicron remnant. They will then go to the liver. Less cholesterol is taken up into the liver then. Less cholesterol is available to be able to make VLDLs, meaning a mild drop in triglycerides. Less cholesterol stimulates the synthesis of LDL receptors to pull more LDL out of the blood and into the liver, and so it'll really drop the LDL. So what type of effect will cholesterol absorption inhibitors primarily have on the actual lipid profile? The primary effect that ezetimibe will have on the actual lipid profile is that it will profoundly drop the patient's LDL. That's really the big thing that I want you to remember here. It'll profoundly drop the patient's LDL with a very minor drop in their triglycerides. But the primary thing is it's going to drop the LDL. So this is why this is actually one of the first line medications if a patient can't tolerate a statin, because it can actually drop the LDL pretty well. Now, one more thing to think about. What are some of the adverse effects? It actually has a very, very mild effect on the LFTs. Very mild. Very rare to actually have this at all, to be honest with you. So I'd actually honestly remember that it's relatively rare, but it's something that we should mention. And it also can cause a little bit of diarrhea, but it's honestly not too bad. It's very mild and not too common. So with that being said, this is a very well-tolerated drug with very little adverse drug reactions, which makes it very appealing for these patient populations who have hyperlipidemia. All right, so PCSK-9 inhibitors. These are actually really interesting proteins, okay? What are the drug names that you want to remember? They're sons of guns. There's like alirocumab and evolocumab. Now, what you really want to remember about these particular drugs is how they actually work. It's really, really cool. So here we have these molecules here. What are these on the hepatocytes? These are hepatocytes. These are your LDL receptors. Now what's really cool is I'm going to draw this here like this black circle here. This protein here is called the PCSK-9 protein. So what is this protein right here called? This is called the PCSK-9 protein. What happens with this PCSK9 protein is it's kind of a signaling protein that really helps to take some of the LDL receptors and endocytose them, So actually this will help with what's called endocytosis. This is mediated via the PCSK9 protein. Once they're endocytosed, they actually combine with something called lysosomes. And lysosomes will actually fuse with this endosome and try to break down and degrade the LDL receptor. So the lysosomes will actually start eating up, and then what they'll do is they'll degrade the LDL receptor. And so the end effect there is that you'll have less LDL receptors that are present on the hepatocyte membrane to bind LDL and bring them into the actual cell. What if I had a drug, which I do, a PCSK9 inhibitor will actually inhibit the PCSK9. So what I'm going to do is I'm going to inhibit every single one of these proteins that are bound to the LDL receptor. I'm going to inhibit the endocytosis, because if these aren't functioning, you can't endocytose. Therefore, I will not allow for any of this lysosome-endosome fusion, and I will decrease the degradation of LDL receptors. And so then what happens to my number of LDL receptors that are present on the membrane? I'm going to increase my number of LDL receptors that are present on the membrane. So these are the drug category here. So we'll just put the PCSK9 inhibitors. They inhibit this actual protein, thus the name. And they excessively increase the number of LDL receptors. They decrease the degradation. So if you have a number of LDL receptors that are normally, this is a normal process. Your normal process is to actually take and endocytose them, degrade them, and then help to make more. But that means you have less of them available to bind onto LDL. If I use this drug, I'll inhibit their endocytosis, their degradation, their recycling process, and I'll keep more of them on the cell membrane. So that means that I have more of these to bind onto LDL particles that are present outside of the hepatocyte. And if they can bind onto these LDL molecules now, they can take more of the LDL molecules in. And so what are they going to do to the LDL levels then effectively? So the LDL levels will be significantly reduced. They'll be significantly reduced. So that is the primary effect out of alirocumab and evolocumab. Their primary effect on the lipid profile is to reduce LDL significantly. Okay? That is pretty much it. There really isn't anything else that you guys should know for its effect. It inhibits the PCSK9 proteins, which inhibits the endocytosis of the LDL receptors, inhibits their degradation by lysosomes, and keeps more of them on the cell membrane to pull more LDL in. That's the whole concept. So if that happens, that means what happens to the amount of LDL that is present within the bloodstream, my friends? The LDL within the bloodstream is going to drop. Beautiful. That is the basic concept that I want you guys to understand about this drug. Now, with the respect to adverse drug reactions or effects, it's very mild, to be honest with you. It may cause a little bit of myalgia, and it may just cause a little bit of injection pain. So a little bit of injection pain because it is given subcutaneously. So it's given subcutaneously, so there may be a little bit of injection pain. Sometimes it may cause a very mild upper respiratory tract type of infection symptoms, but for the most part, the most common adverse drug reactions is myalgia and injection site pain. That's really it. So it's a very, very good drug that has the ability to significantly decrease the patient's LDL within the bloodstream. Okay, that covers all of the categories of drugs. We've covered the HMG-CoA reductase inhibitors. We covered niacin. We covered fibrates. We covered bile acid sequestrants. We covered cholesterol absorption inhibitors, and we finished off with PCSK9 inhibitors. We now know all of their mechanism of action. We know what's their primary effect on the lipid profile. We know their adverse drug reactions. Now, and we know their names. What is the last thing that we should talk about? A patient comes in, they have hyperlipidemia, whether it be due to high LDL, low HDL, high triglycerides. How do we approach these patients? What's the ways that I would know when to start lipid-lowering agents, which agents to start them on, and when to add on these other ones besides the statin? Let's talk about it. All right, my friends, so patient comes in. They have some type of problem where you need to consider putting them on a lipid-lowering agent. When a patient comes in, and they have any types of clinical atherosclerotic cardiovascular disease, that is an indication to start them on some type of lipid-lowering med. The most common one that you're going to put them on, what's the first line? I said it at the beginning of the video, and I've said it throughout multiple processes that statins are going to be your first line. So we should focus our attention on statins here. So patient comes in, they have any type of clinical atherosclerotic cardiovascular disease. What does that mean? They suffer a stroke, they suffer an MI, they have peripheral artery disease. Any of these that are actually some type of event like that, you start them on a statin. Now, with that being said, if they suffered one of these events, you have to think about the patient's age. The older they are, the more likely they are to experience side effects, and that's the problem, especially myopathy. So it's important to think about that. Is the patient greater than 75 years of age, or are they less than 75 years of age? At greater than 75, you probably don't want to be blasting these poor patients with high-intensity statins. So what I would say is, for this patient population, consider some type of moderate intensity statin. So this means that you can consider rosuvastatin less than 20 milligrams, atorvastatin less than 40 milligrams, or lovastatin, fluvastatin, simvastatin, pravastatin. Okay, just think about that. And the reason why is a lot of the myopathic effect. All right, and just the true benefit that they would gain being already above 75 years of age at this point. If they're less than 75, you want to be aggressive. They have a potential to live a lot longer. And so because of that, you don't want to play around, and you want to put these patients on high intensity statins. Okay, high intensity statins. So again, in this situation, you're putting them on greater than 20 milligrams of rosuvastatin or greater than 40 milligrams of atorvastatin. Okay. The next situation here is if the patient has a whopping LDL that is greater than, my gosh, I could imagine this, greater than 190 milligrams per DL. If that LDL is that high, you have a very high risk of atherosclerotic cardiovascular disease. Okay, because of that, because your risk now, you have a very high risk of atherosclerotic cardiovascular disease and many other complications here. You really need to get on top of these patients. You don't want to delay. And so for these patients, regardless of any other type of parameter, you start them on high intensity statins. High intensity statin. And so this would be your rosuvastatin greater than 20 milligrams or your atorvastatin greater than 40 milligrams. Okay? Next category. So this one's kind of a couple hitter here. So we have a patient who has diabetes mellitus. Okay? They also are 45 to 70 years of age. So 45 to 70 years of age. And then the last component here is you look at their atherosclerotic cardiovascular disease risks. That's the third parameter that you add on here, but that's going to lead to this dichotomy here. So you take into consideration a patient who's diabetic. Diabetes definitely increases the risk of atherosclerotic cardiovascular disease, right? And hyperlipidemia. It's really important because what it does is it actually oxidizes LDL, which increases a lot of those problematic plaques that you see within these patients. So diabetes is a very high risk factor for hyperlipidemia, and it can lead to a lot of oxidized LDL particles, which really can accelerate a lot of the plaquey process. And if a patient's like this age, you really want to be careful with that. So what you do is you risk stratify these patients into two categories, and you look at their atherosclerotic cardiovascular disease risk calculation. So if you guys go into MD Calc and you put in their risk factor calculation, their percentage based upon their atherosclerotic cardiovascular disease, you're looking at a particular number. What you want to know is it greater than 7.5% or is it less than 7.5%? If your risk is greater than 7.5%, you're at high risk of a clinical atherosclerotic event. So because of that, you need to be on a high intensity statin. If your risk is less than 7.5, you don't need to be as aggressive. You're at less risk of a clinical event. So for these patients, you want to do high intensity statin. And then for this patient population, you can relax a little bit and do a moderate intensity statin. The last category is you have a patient who is not diabetic, but they are 45 to 70 years of age. And again, you're really just looking at this patient population and trying to figure out, is this patient population, are they greater than, is there atherosclerotic cardiovascular disease? So again, for this one, it's 45 and they have an atherosclerotic cardiovascular disease risk greater than 7.5%. If they do, this patient will qualify for a moderate intensity statin. So let's recap this again. Patient comes in, they have a clinical atherosclerotic cardiovascular disease event. If they're greater than 75, you can do moderate intensity. If it's less than 75, you can do high intensity. If their LDL is greater than 190, they're super high risk, high intensity statin. If they have diabetes, which now puts them at high risk for hyperlipidemia and atherosclerotic cardiovascular disease, helps cause excessive oxidation of LDL particles and really forms a lot of plaques, these patients are high risk. Determine their risk by stratifying them and based upon their calculation. Is it less than 7.5 or greater than 7.5? If it's greater than 7.5, high intensity. Less, moderate intensity. And then the last one is a patient who doesn't have diabetes, but their risk is greater than 7.5% for an event, and they're 40 to 75, you do a moderate intensity statin. Okay, that covers how we treat these patients. So you can obviously see that the first drug that we talked about is going to be the drug of choice no matter what. What we really want to think about is, what if the patient is having an adverse drug reaction? They can't tolerate their statin, and so we need an alternative. Then we can think about other drugs. But I think the better thing is, if a patient maybe is on a statin and they're still not at goal, you could add on another medication to have a combo therapy. So it is important to realize, yes, if statins aren't working, the next best choice could be one of the drugs that we talked about in these scenarios. It could be things like we talked about, cholesterol absorption inhibitors are really, really good, or maybe even something like, your bile acid sequestrants could be a potential option. We'll go through all of these things. But I think the easiest way to remember it is, if you have to do a combo therapy or you can't do a statin, treat them based upon which parameter of the lipid profile they improve. So let's talk about that now. All right, so I want you to think about this in two ways. Combo therapy, a patient who's on a statin, they're on that statin to be able to lower their LDL, to increase their HDL, to decrease their triglycerides. We know that that drug can do all three effects, right? They may be on the statin, but they're still not at their goal. So we still haven't gotten that LDL below the goal that we want. And obviously the LDL goals can depend. Generally, optimally, you want it to be LDL less than 100 would be a nice goal, and HDL greater than 60 would be a nice goal. So I think that's important to think about, that if you have a patient who's on a statin and you maximize that without causing a lot of adverse drug reactions, and they're still not hitting that goal, then what drugs would I add on? Well, it depends. That's why I talked about the lipid profile so intensely. What if I have a patient who still has a high LDL? So then I want to think about which drugs really lower the LDL, which drugs really lower the triglycerides, and which drugs really increase my HDL. Because if I'm not meeting my goal, it might be good to know which drugs actually approach that and add those drugs on accordingly. So I want to know now, okay, I have a patient who's on a statin, but their LDL is not at goal. Their triglycerides are not at goal. And then they're also, HDL is not at a goal that I would like. Which drugs could I add on? That's a pretty cool concept now. And so really with these, the first thing that I want you to think about is two particular drug categories. One is if they're on a statin and they're not responding to it, or let's say that they're not even on a statin. You could consider a PCSK-9 inhibitor. This is a really good drug that drops your LDL. The other one is the cholesterol absorption inhibitor, would be another really good one called ezetimibe. Now, if the patient fails ezetimibe or they can't take ezetimibe, then you can add on two other drugs. Then this would be the bile acid sequestrants. Just be careful if they have hypertriglyceridemia. And then the other one would be niacin, because niacin has somewhat of a decent effect on dropping LDL, but it's not going to be the absolute best. So here is the patient who is on a statin, right? So this patient is on some type of statin, and you want to know, what else could I add on to the mix? Or maybe they did a statin, couldn't tolerate it. What other drug would be another option? So if I'm trying to drop LDL, PCSK9 inhibitors is one option. The other one is ezetimibe. If they fail ezetimibe, so let's actually put here with a negative sign here, they fail ezetimibe, then you can go to bile acid sequestrants or niacin as an option. Okay. Patient has triglycerides that are still high at goal with their statin or they can't tolerate a statin. Which drugs would be able to be added on here? We already know which ones. Which ones drop them? Niacin and fibrates. That's it. Niacin and fibrates are great at dropping the triglycerides, and they're also good at dropping what else? The next drug category. So the ones that increase HDL. Because niacin inhibits what? Inhibits the hormone-sensitive lipase, so you don't break down triglycerides into free fatty acids, don't get utilized by the liver to make VLDL, so you have less VLDLs to be utilized to drop off triglycerides, so it drops triglycerides. It also inhibits this, macrophages from catabolizing HDL and decreases reuptake. Fibrates stimulate HDL synthesis, but it also stimulates lipoprotein lipase. So you break down a lot of the triglycerides from the VLDLs and chylomicrons. So these are great. Which one's better? Which one's better at dropping triglycerides though? Fibrates will be better. Okay? Then the next thing is HDL. If a patient has super high HDL, there are two drugs that would actually do that, is the same ones that drop the triglycerides. So niacin and fibrates. Niacin and fibrates. So these are the ones that I really want you guys to think about. Now, the question that you may have is, how do I know which one to pick? It depends upon the patient's history and their adverse drug reactions. If I have a patient whose triglycerides or HDL is not at goal and I got to figure out, okay, which one do I do, niacin or fibrates? If a patient has some underlying cholelithiasis already, that might not be a good idea to maybe do something like a fibrate. I better be very careful with that. If a patient has some type of they're already on a statin, I better be careful with giving them a fibrate because they may actually increase their myopathy. If a patient's on niacin, I better be careful that if they have gout or if they have hyperglycemia with diabetes, or also be careful that they have a lot of the reaction of the flushing and the pruritus and the redness. You get the point. With PCSK9 inhibitors, they're very well tolerated. With ezetimibe, it's really well tolerated. But if they fail this one or they can't tolerate this one, then you get into these two drugs. And then bile acid sequestrants, you got to be careful. It can increase your triglycerides. It can reduce the absorption of fat-soluble vitamins. It can block the digoxin and warfarin absorption. That's a problematic thing. So thinking about the adverse drug reactions and the problematic issues that can come from that will help you to determine which is the best option here. I hope this made sense. If it didn't, let's actually do some practice problems to reinforce it. All right, guys, so here we go. Which of the following is the most common adverse effect of anti-hyperlipidemic drug therapy? Interesting. Elevated BP, GI disturbance, neurologic problems, heart palpitations. I think none of them mentioned anything about an elevated blood pressure. If anything, it might actually lower their blood pressure. Gastrointestinal disturbances, yes, there was some of them that had risk of diarrhea. Some of them could have GI upset. Some of them could have hepatitis. So yes, I'd say gastrointestinal, sure. Neurologic, if anything, it's actually going to decrease the risk of kind of strokes. And then heart palpitations, no, it'll actually probably likely decrease the risk of heart palpitations. So again, I don't think any of these other than gastrointestinal disturbance would be the correct answer. Which of these drugs decrease cholesterol synthesis by inhibiting the 3-hydroxy-3-methylglutaryl coenzyme A reductase? Another name for this enzyme is called HMG-CoA reductase. So it's the same thing. Which one of these would do that? It has to be a statin, an HMG-CoA reductase inhibitor, so it's C, lovastatin. Which of the following non-statin drugs lowers LDL? C, most effectively just lowers LDL. It's got to be the PCSK-9 inhibitors, because they just massively decrease the amount of LDL receptor degradation and increase the LDL receptors and cause massive decrease in LDL. So it has to be PCSK9. That was the CUMABs, so B. Which of the following drugs binds bile acid? So it has to be a bile acid sequestrant in the intestine, thus preventing the return to the liver via the enterohepatic circulation. And if you remember, less bile acids, cholesterol's got to make a lot of it, less LDL receptors. So it actually increases the synthesis of LDL receptors. You pull more LDL into the actual liver cell, but it also can increase the synthesis of triglycerides. This was the bile acid sequestrants. Which one is this? Cholestyramine, cholestyramine, or cholestyramine? So it's got to be C, cholestyramine. 65-year-old man has type 2 diabetes and LDL of 165. Which of the following is the best option to lower LDL and decrease the risk of atherosclerotic cardiovascular disease events in this patient population? So for this patient, again, what's the first line drug to decrease atherosclerotic cardiovascular disease? It's statins. They didn't mention in here what's the category and which one's the high intensity, moderate intensity, all of those things. But again, if it was a 65-year-old, so that's 40 to 75, they have diabetes, and let's say that their atherosclerotic cardiovascular disease risk was less than 7.5%, you could go with a moderate intensity, and if it was greater than 7.5, it would be a high intensity. But in general, it's going to be a statin, rosuvastatin. Okay, next one. 62-year-old female with hyperlipidemia, hypothyroidism is prescribed cholestyramine and levothyroxine. What advice would you give her to avoid the drug interaction between these two? Well, again, remember, cholestyramine can bind drugs. The two most common ones is going to be digoxin, warfarin, and then the third one would be levothyroxine. So it's better to just give the levothyroxine first, have it actually start getting absorbed first, and then give the cholestyramine so it doesn't bind it up and inhibit its absorption. So I'd take the drug first, levothyroxine, and then the cholestyramine later. So take levothyroxine 1 hour before cholestyramine. Yes. Adverse effect of niacin. Okay, so here we go. A 72-year-old male started on sustained release niacin 2 weeks ago. He reports uncomfortable flushing and itchiness that he thinks is related to the niacin. Definitely the case. Which of the following can help manage the adverse effect of niacin therapy? Well, remember, niacin increases prostaglandin synthesis, causing vasodilation, causing increased capillary permeability, causing flushing, redness, and as well as causing pruritus via the histamine release. If we give a drug that inhibits the prostaglandin synthesis via the COX-2 enzyme, aspirin, ibuprofen, you would give that patient that. Now, the question that they're trying to trick you is, would you give it before or after? Give it before, because once you give the drug, it's going to likely hit that pathway. So if you give it before, again, aspirin is going to have no other effect other than just inhibiting the prostaglandin synthesis. It's not going to alter all the other effects of niacin that it has on the lipid lowering effect. So just give it before you give the niacin so that it can shut that down so that niacin won't hit that pathway. So it would be before taking niacin. Hyperlipidemia and renal insufficiency. Okay, so a 72-year-old man with hyperlipidemia and renal insufficiency has been treated with a high-intensity atorvastatin, so greater than 40 milligrams for 6 months. His LDL is 131, still not a goal. Triglycerides, oh my gosh, 710, and HDL 32. He's in big trouble. His physician wishes to add on another agent for hyperlipidemia. Which is the best option to address the hyperlipidemia in this patient? So they have a high LDL, and they have a heck of a triglycerides. They're already on a statin, so this is the combo therapy. Which one of these drugs has the ability to lower triglycerides? Well, fenofibrate, yes, it lowers triglycerides pretty significantly. Niacin will drop triglycerides. Cholestyramine, no, it actually will increase triglycerides. And gemfibrozil, a very mild drop in triglycerides. So really, it's B or A. Now, I told you which one's better. Fibrates will significantly drop your triglycerides. Niacin will also, but fibrates are definitely going to be better. So your answer would be like, oh, it's fibrates. There's one downside. Niacin is not as much renally excreted as compared to fibrates. So fibrates are extremely renally excreted. And so if a patient has renal insufficiency, that would be a potential contraindication or a downside to giving fibrates. That's one thing that you got to be careful for. So because they have renal insufficiency, I would not give them a fibrate, and instead I would give them niacin. So that is the only other caveat to this. All right, last question. Which patient population is most likely to experience myalgia or myopathy with the use of HMG-CoA reductase inhibitors? Well, anything that increases the amount of HMG-CoA reductase inhibitors. So if a patient's renal failure, it's renally excreted. So yes, they will have higher levels of that drug, which means that they'll deplete the coenzyme Q and then definitely cause myopathy. Patients with gout, that has nothing to do with it. Hypertriglyceridemia, nothing to do with it. Patients taking warfarin, nothing to do with it. So patients with renal insufficiency, yes, because you're going to not excrete as much of the statins into the actual urine, and you're going to have more of it kind of just flooding your bloodstream and causing depletion of coenzyme Q. So yes, A. All right, my friends, that covers the questions and the cases. That covers the actual lecture on lipid-lowering medications. I hope it made sense. Hope that you guys enjoyed it. And as always, until next time, see you, Ninja Nerds.